So today we're going to start with our physical medicine and rehabilitation lesson with Dr. Dugan. I'm going to go over an introduction and then let her introduce herself, and then we'll get going. So physical medicine and rehabilitation physicians, also known as physiatrists, treat a wide variety of medical conditions affecting the brain, spinal cord, nerves, bones, joints, ligaments, muscles, and tendons. Pm&R physicians are medical doctors who have completed training in the specialty of physical medicine and rehabilitation and may be subspecially certified in brain injury medicine, hospice, palliative medicine, neuromuscular medicine, pain medicine, pediatric rehabilitation, spinal cord injury medicine, and or sports medicine. Specifically, Pm&R physicians treat patients of all ages, focuses on treatment of function, and lots more, and I'll let Dr. Dugan explain all of that after she introduces herself.
Thank you very much. Yes, hello, I'm Dr. Sheila Dugan. I work with Selby and others, and I am a doctor of physical medicine and rehabilitation. Sometimes we're called Pm&R, like apostrophe, or ampersand R. Or a physiatrist. Mm-hmm. And I work here at Rush University Medical Center, where I've been for about 20 years. And in this setting, I am also the head of a department of all the other Pm&R doctors. So we take care of, as we mentioned, anything from the brain or the spinal cord, like people that have a stroke or a spinal cord injury that need to be in the hospital. But I spend my time taking care of outpatients. So that's sports medicine, the bone, joint, tendon, all the stuff that gets in our way for us trying to be functional and be doing our regular exercise. Physical medicine and rehabilitation is a specialty that you take 4 years of training after your 4 years of medical school, which happens after 4 years of college. So it's a commitment. Like many things in healthcare, you need to have hands-on experience and you have a lot of book learning. And then we do a residency where we work beside senior physicians and make sure that we're doing things correctly and accurately. And then some people do go on and get, like we mentioned, a sports medicine fellowship, which I happen to have as well, so that they can work closely with people who have musculoskeletal problems.
Mm-hmm. Okay. So you talked about how you worked in outpatient. Can you go over some of the differences between outpatient, inpatient, and maybe if you work in a rehab center, those type of things?
Absolutely. So as I mentioned, you might need hospital care and sleep at the hospital overnight, and then you would have a doctor who admits you to the hospital and is responsible for all of your medications. If you needed oxygen, making plans like with social work about when it's time to go home and what you might need. On the outpatient side of the house, we work with people that are living at home that have problems with something that happened at work or something that happened at their practice if they're a kiddo playing sports, something that happened because you decided to go to the gym, and something that happened because you slipped down the steps coming out of church. So anything that could happen to you that gets in the way of your function or causes you to have pain. Sometimes we have to rule out that something bad happened, like you broke a bone. So there is an element of listening to the outpatient, examining him or her, deciding what kind of test might I need today, and then making a plan that you then have a whole team of people that you work with to help the person meet their goals of having less pain or being able to get back to their job or their hobby.
Okay. So when somebody has that event or they need to come see you, what does a visit look like, and maybe how does it differ from their like normal doctor's visit?
Great question. Like yesterday, I had someone come in who said, and by the way, could you do my clearance for the surgery I'm having next week? And I said, no, because I'm not a primary doctor. I can't do an EKG today and some of the things you need to get cleared. My visit is really about what is your chief complaint, what brings you in today, and then asking questions about the history of that so I can better understand, like, did you pull a muscle or did you slip and something could have ruptured? So the history is really important. And after you do the history, then you plan your physical exam. For me, I usually have folks get into a gown because I want to make sure are their muscles the correct size? Let's say you had a nerve injury that was causing damage. It's really important to see that muscle smaller on one side compared to the other. So then we do the physical exam. And then sometimes we do some tests kind of in the office or even a treatment in the office. Let's say your knee is very swollen. You have limited ability to move it. And I'm worried that there's fluid in your knee that needs to be drained. Yep. And sometimes you might leave behind like a steroid injection. Okay. So sometimes the appointment also includes a procedure, either a diagnostic procedure or a treatment procedure. And then usually you're sent home with a list of things to do, including like write me a note back, what we call my chart, to say, how is that medicine helping? How does your knee feel after we drain the fluid? Okay. Or did you get your physical therapy as I recommended? And if so, you're having trouble, how do I help you make that happen?
Can you go through some of the most common reasons someone would come see you, or some more the common treatment things that you would do for those?
Absolutely. I would say in the general community of adults, it's probably back pain, followed by knee pain, followed by shoulder pain.
Yep.
Probably as a trainer, you see that too, because of the stuff you're having people do. If people are training for an event, let's say a runner, it might be a lower body injury, a foot, a leg, a knee. If somebody's got a repetitive job lifting things overhead, or they took on a new weightlifting program, then it might be more like shoulders. Lastly, I guess with people typing and stuff on the computer, it might be their wrists.
Okay.
And again, we would then want to look at things like, what's their motion? Is there anything tender? Do I need to think about, ice or anti-inflammatory or an injection? And sometimes we start with the least invasive first. Like, let's try some medications, a little bit of rest, not too much rest, rest, ice, compression, elevation. And then they get back in touch with me to decide, is there something more invasive that we need to do? Okay.
And since we talked about earlier that this specialty isn't as well known as other specialties, is there a specific way that someone, like how someone can come see you? And then once they come see you, is there any specific, like those specific interventions you talked about, are there anything that's different from going to your regular doctor?
Yeah, I do think that we sometimes think about, let me see an orthopedic surgeon if you hurt something. Orthopedic surgeons want to operate on you. And the office is set up to have people come in that need to be evaluated for surgery and then taken to the operating room. So if you come in with something that isn't surgical, you may not be as exciting to the provider. So I think physical medicine and rehab, we focus on function, and we're in that place where you don't need surgery, but you need something. Just because the x-ray was negative, or because they did you had the colonoscopy, and so your colon's okay, but you're still having a lot of belly pain. There's other parts of the body that are, like you said, muscles, tendons, joints, that can cause these problems that other doctors just aren't familiar with because it's not their thing. Whereas I'm not a GI doctor, so if I'm treating someone with belly pain and it's not getting better from a muscle perspective, I need my partners. And the same thing goes with neurology. If you need to be diagnosed with, let's say, ALS or MS, you might be seeing a neurologist. But if you're trying to manage all the parts of using your equipment and being able to walk and exercise, then the physical medicine and rehab doctor might join the team. So we're really all about working with other physicians, other physical therapists, occupational therapists, podiatrists, people that make braces, prosthetists, orthotists. Somebody has an amputation, we help with figuring out, do they need a lower limb prosthesis? We do the orders. So it's a really fun, collaborative kind of medicine, which I really love about it.
That's good. Can you talk about how you work with some of the other, team members around, like maybe the physical therapist connection, or do they have to come see you first before they go to physical therapy?
Yeah, so right now, let's say you wanted to come and see someone about your sports medicine injury. You could self-refer for physical therapy, and new in the state of Illinois where I work, I think you can have up to 6 visits with the physical therapist, which was different than, I was a physical therapist back in the 1980s. You had to have a doctor's order. You could even come and ask to see me. Hey, I want to see Dr. Dugan or the rehab doctor because my knee hurts. In some insurances, you have to go to your primary doctor first. So if you have an HMO, you have to ask your primary doctor to write you a letter to a specialist and an order that says, please see Sheila Dugan in physical medicine or rehab. But many times you can refer yourself. And many times people see me that says, hey, my neighbor saw you, or there was another person in an exercise class that had a good experience with you. So I just self-referred.
Okay. And then speaking of insurance, is there any restrictions or limits on like maybe follow-ups, or how long does that relationship last when someone comes to see you about an injury that might not require surgery?
Yeah, I would say that insurance is really funny about how many visits of physical therapy you can have. I think when it comes to your physician office visit, you aren't restricted that way, but we don't usually see people 6 times. Usually I have a plan, and then I say, go see physical therapy. I will reach out to the physical therapist, how's it going? And if it's not going well, I might see the patient back. But if it's going well, I may never see them back in the office. It's almost like, if it's not going well, do we need a new test like an MRI? And then I'm going to refer you on to a surgeon or somebody to do an injection under x-ray guidance or other types of care. That's where you need that teamwork.
Okay.
Yeah.
The last thing I know we touched on a little bit, but I guess the overall thought process of sports medicine is you have to be like a professional athlete to see a sports medicine doctor or something like that. But like you mentioned, there are real general things that you can help deal with. Can you talk about, have you ever dealt with any athletes or professional sports medicine situation?
Absolutely. So when you get your sports medicine fellowship, part of your training is on the side of the field, on the field side, where something happens during the sport. I was at the Winter Olympics in 2002, the Paralympic Games, where people get injured. There was a skier who actually had a big swollen knee, and I had to drain his knee because he was about ready to go down the hill, which, as an aside, he was sight impaired, and it was pretty impressive to watch somebody with somebody next to him telling him, turn. It was pretty amazing. I had a lot of gratitude for that experience. But I consider all of us athletes, especially when we're trying to get moving for our chronic health conditions.
I agree.
So just like somebody who's this extreme athlete has to work hard and something gets overdone or it's injured. Even when we're starting out, we have a lot of problems with my knee hurts a bit. Should I keep going? My back's sore. It's radiating down my leg. So all of us are athletes of a type. And so everybody deserves to get seen by someone for their sports medicine, their exercise-related injury. And lastly, sometimes when you're in your PCP office, they're worrying about your mammogram, your colonoscopy, and then you're like, hey, by the way, my knee hurts. Yep. And then it just kind of gets lost in the shuffle. Yep. So definitely advocate for yourself, because being able to exercise is so crucial to your health and your physical activity, and you don't want to get sidelined.
Yes, agreed. Although if people do need to come see you, of course, you'd be the best person to go to, but is there any advice that you would give people to not have to see a physical therapist or a PM&R doctor, more of like a maintenance thing that they can do?
I'm a big fan of stretching. And I like yoga as a way to have some organization around how I'm stretching. Yoga addresses the usual postural tightness we have when we live in the United States and we're seated a lot. It also reminds us to relax and breathe, because the other thing that causes stress and pain is just the tension of life. Yep. And now more than ever, we have a lot of tension. So just having like 30 minutes where you're just thinking about laying and breathing and stretching can be super helpful. And then you go out and, get your heart rate up, lift your weights, do all the stuff that, the trainer wants you to do. Yep. But I think that other moment of relaxing and stretching is probably a really good injury prevention thing to do.
Well, do you have any closing remarks for the participants that you would like to give? Slow and steady. Yeah, just, we can all change the way we can move and we can lift and we can stretch at any age. So just stay with it. And if you have a little setback, take a breather, take it back a notch, but stay on your course of physical activity, because it's really, really important for your health and your wellness. Sounds good. Thank you for all the information.
You're welcome.